So probably this is the last talk of this session and the conference. So we had a great meeting. So I was talking about posterior polar cataract. So beginners should master each and every steps of phaco, such as, for an example, the sections. Here I am doing a keep a eye and here I am doing a topical phaco and doing a side port. What is the problem? I don't. And have a look, the patient just moved his eyes and the section enlarged. So you have to be careful while doing a PPC where the chamber maintenance is very important. So I should have holded the blade other side round, because normally the patients, they move their eyes upward, and because my blade cutting edge was downward, it extended, and now the problem starts. Especially if you're doing a PPC cataract, the chances of the posterior capsule opening becomes imminent. So the second thing is the section. For section, they do in their different way. What I normally do, nick the anterior capsule with the keratome blade itself. That is not the point which I am trying to show, but what we do, the flap is already raised, and then try to keep the rexis slightly on the smaller side, say 5.5 or 5, so that if you are doing a 3-piece IOL insertion, if the posterior capsule open up, if you are doing a 3-piece IOL insertion, you can always do a iris capture if you have a adequately sized rexis. So second thing you should master as beginner is the rexis. And once you have done the rexis, the next step is hydro dissection. Now hydro dissection is a big no-no for the beginners. I know there are seniors who are talking about hydro dissections because they have the anterior segment intraoperative OCT, but otherwise you shouldn't. You either take a spatula, separate the capsule, anterior capsule from the thing, or use little bit of hydro fluids just to separate the anterior capsule. So this is what you should do. Now regarding the management of the nucleus, again chamber maintenance is very important. Here what I am showing, I haven't done any hydro dissection. No rotation of the nucleus should be done. In soft cataract you can just engulf it, but little bit of hard cataract, what I have done now, I have taken a pie out. Still I am not rotating. Instead of rotating the nucleus, I am rotating the tip of the phaco and bringing it at 3 o'clock and trying to get another piece out. So once you have done that, you can engulf it. So you now have 50% of your nucleus out. So now if you drop, you have to pay your colleague only 50%. Okay, if you have to pay your retinal colleague only 50% if you drop the nucleus now. Now what I am doing, I am just trying to get hold of the upper half, nudging it out of the capsule without rotating, and then chopping it into pieces. So what I have shown is, without rotating the nucleus, you can effectively do phaco in posterior polar cataract. And as a beginner, you should practice this in normal cataract without hydro dissection. Try to rotate, and then you can give up and hydro dissect and do the thing, but you should practice in this normal cataract. Now important thing is not to decompress your chamber. So what you have seen, what I have done, instead of taking the phaco piece out, hand piece out, I have used my visco to form the chamber, then taken the phaco piece out. And what I am doing next, if you remember, initially I separated the capsule. From there now I am injecting visco, you call visco dissection, and separating the nucleus up to the attachment of the posterior pole. So then it becomes removal of the epinucleus much easier. And what I am doing now is using my second handpiece is my visco cannula, so that whenever there is any chance of decompression, I am injecting visco to maintain the chamber. So once the epinucleus is out, you can inject little bit of more visco and then take your phaco tip out. So the chamber is maintained. Now regarding IA is very important, because you don't, 90% of the job is done. You don't need to have lost for the last 10%. So it is important that if a pupil is small, you can manage either with iris hook, or you can just nudge the iris away with the second instrument. But important thing is that don't try to polish the capsule. In PPC, you can always do YAG later on, or if you are a pediatric surgeon, okay, you can open up the capsule, do a rexis, but if you are not, then don't try to polish the capsule. As you have seen, a fool like me, I tried to polish the capsule here and the PC opened up. Luckily, it was not a small, big opening, it was a small opening, and I managed to put the lens in the bag, and as you see, I have kept my irrigation on, not allowing it to decompress, so that the it's not opening up, and then I managed to put the lens in. And if the PC open up, you need to know how to manage your case, or you have to take help of your senior, because if you are trying to do initial phase, you have to take your help of the junior. Here the PC opened up, so after putting good amount of cohesive viscoelastic, dispersive viscoelastic, I am trying to get move the little bit of cortex which was left. So here what you do, you try to move it in a sideways fashion and then bring it out, and always try to maintain the chamber. And once this is done, then you have to reassess whether you can put the lens in the bag or whether you can put the lens in the sulcus. Preferably, I think we should try to put it in the sulcus, because you don't know whether while injecting the thing it will open up. So here I am putting a 3-piece lens, as there are several ways of doing that. What I am doing here, I am directly going in between the capsule and the iris, but you can always press it on the iris and then put it back. So whichever technique you are familiar with, you can use. So once you have put the first haptic between the iris and the sulcus, then you can dial in, or you can use a McPherson to put the capsule, put the trailing haptic over the anterior capsule. And always remember to use triamcinolone to make sure there is no remnant vitreous. Whatever vitreous there in the anterior chamber, you can go in and trim off whatever vitreous is there, and then you can use pilocarpine as well to see whether there is any peaking of the pupil. That also can give a hint, and then form the anterior chamber. Here I couldn't show the capsule capture very well, but that's how you progress. So I think it just okay, it's causing some problem. So I'll end my talk here. Thank you for your patience hearing.
Thanks a lot, Sugato, for a very lovely video presentation on the posterior polar cataract. Any questions from the audience, or anybody wants to add some points to what has already been spoken so far? Yeah, Harshul.
Sorry? Yes, so that's what I showed. If the PC is ruptured, yes. So the last video was with the large, if you have noticed, it was a vertical split of the posterior capsule. The last video was a vertical split of the posterior capsule, where I decided to do the lens on the sulcus and did vitrectomy. So that is important to do. And if you have a PCR while doing the phaco, if it opens up and there is nucleus drop, then you have to take help of your colleague. First vitrectomy if there is vitreous, then lens. So here it was opened up, vitrectomy was done, then I did the IA and then put the lens, then whatever remnant vitreous was there with triamcinolone, I cut it off.
So just to highlight this point, if you're just to highlight that point, if we are sure about the anterior capsular integrity, you have an intact rexis,
yes,
and rest of the capsule is fine, then even if the PC lens is very large, even larger than what you had shown, you can still keep the lens, 3-piece lens in the sulcus with an optic capture.
Yes.
That gives a very stable, it locks the lens pretty well for times to come.
And I think for the size for the capture should not be more than 4.75 or 5. So then only you can capture it very well. So the size was a little bit larger.
Yes, for this it was 5.5. Yeah. So that's what I said. It should be between 5.5 and 5 rather, so that you can capture.
4.75 to 5 is ideal size.
Now see, when we make a rexis, we don't really measure it, but the dictamen in a posterior polar cataract is don't make a large rixis. That
Yes.
is,
Yes.
don't make anything
Yeah.
more than 5.5.
Yes.
4.5 to 5.5, I think is stable. It's basically that you need a good uniform overlap all around. Otherwise, it may again be pushed
Yeah.
out of the bag, and
Yeah.
you know it
Yeah.
may lose its stability, and
Yeah.
it may, you know, the power may change.
Yeah.
Yes, John.
And
Sugata?
See, in this video I was using Centurion with 90, so sorry, Infinity. So I normally keep it at 110, but it was 90, so I didn't pay any attention on that. Sorry. Huh. IOP normally my IOP nowadays varies from 20 to 40 for Centurion. Oblique shape, someone proponent that you
Oval
can do
rexis,
applique capture.
oval
Oval,
rexis.
oblique, yeah. Yeah.
but I don't think that it can anyway save you from, you know, in a true posterior polar like this where it has to open, it will open. It can't save you from this. So I'm talking about true posterior polar, not the subcapsular which looks like polar. Because in the end it will open up. Like this case was a true posterior
Yeah.
polar where you have a split like this.
So 10% of the posterior polar, I think they open up whatever you do, but you have to be hopeful that it don't open up during the phacoemulsification.
Yes.
If it opens up during the IA or thing, you can pretty well manage them.
See, the thing is, we cannot say that only if the posterior capsule opens up, it is a true PPC.
No.
Because of iatrogenic errors, because of surgeon errors,
Yeah,
it
of
can
course.
open up, you know.
Yes.
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 So that is the reason the oval rixis comes to the picture, because it is aligned along with the paracentesis. So the manipulations and the chopper manipulations become easier.
I,
Yeah. But then it is again, it's not that
Chance
it has to
of-
be, it's a surgeon dependent factor.
See, I think parameter higher will not make a much difference, but if you are rotating the nucleus, that can open up the PC. And one thing is, as Dr. Herschel was saying, that you have to be vigilant, because once I had, it was PPC, I did the phaco, I did the bimanual from one side with chamber maintenance, and I thought, okay, I have done, and I took out the hand pieces to change over the hand, that it opened up.
Yeah, I think,
So-
you know, we have to put an end to this,
Yeah.
because we are expecting Rajesh and he has come.
Oh, Rajesh,
And-
oh, sorry, Dr. Sinha has
We'll
come.
take up the talks later.